So ASH was, I think an interesting meeting looking at lymphoma highlights. What we saw, I think, in terms of aggressive histology lymphoma were some interesting data looking at the variety of bispecific antibodies targeting CD3 and CD20. So in the absence of comparative data at this point, they all look very good in terms of efficacy, and the toxicity is being well sorted out, though there are differences between the platforms in terms of how toxicity may be mitigated. And at least one of the drugs, epcoritamab, now has presented pivotal data using a subcutaneous formulation, which may be an advantage, even though we have to sort out details around hospitalization and the management of patients with toxicity. Looking at indolent lymphoma, I think the theme there was largely around looking at some of the data from CAR T cells, also looking at small molecules such as PI3 kinase inhibitors and BTK inhibitors, where in diseases like Waldenstrom's or marginal zone lymphoma, we saw drugs demonstrating good single agent activity and reasonable progression-free survival, though again, in the absence of randomization, it's really hard to tell how these benchmark versus some standard immunochemotherapy approaches that might have been used. In Hodgkin's lymphoma, there were actually a couple of interesting presentations that looked at novel strategies, and one of them came from the group at Memorial, where they combined Pembrolizumab with Gemcitabine, Vinorelbine, and Doxil in potentially transplant-eligible patients, which showed an exceedingly high complete remission rate. Now, again, it was a smaller study and uncontrolled, and we know that adding novel therapy, whether it's BV or a checkpoint inhibitor to salvage regimens, can lead to a very high CR rate. And so these results look really encouraging for our second-line patients that are transplant eligible, but do lead to other questions, such as, do we need transplant? At some point, could we do trials to look at that question? And can we optimize and show that one of these salvage approaches is really worthy of being called the new gold standard? But control data will be needed for that. One of the other interesting ones, just to highlight another new drug, is Cami. So that's the CD25 directed antibody drug conjugate from ADC Therapeutics. This is now undergoing a pivotal trial in Hodgkin's lymphoma, typically in patients that have been exposed to things like BV and checkpoint inhibitors previously. So this was a preliminary analysis that was triggered by some safety events. The drug was known to cause a Guillain-Barré-like syndrome, and the trial protocol is written, dictated an early look should they see 3 of these events. And so that look was required, as they had 3 Guillain-Barré events in this study. But what we saw interestingly in the phase 2 study was confirmation of the excellent response rate. It was about 80%, which compares favorably with the phase 1 experience that was presented by Graham Collins back at the Lugano meeting. I think highlights, again, an important point in Hodgkin's lymphoma, where you see efficacy from this new approach when we're sort of lacking things for the population that has gone on to have BV or checkpoint inhibitors and had disease progression thereafter, but an important concern around toxicity. And so I think the question there might have been, brought up well in the question panel, where they said, how many of these events is too many? And the comment may be any toxicity like this is not really wanted, but that needs to be put in context because so many patients are benefiting. And so can this be optimized from a management standpoint?